Thank you all for joining us for our final Medical Student Grand Rounds seminar of 2020. After today, we will take a break until the new year, but please mark your calendars for the first and third Tuesdays of each month at 12 p.m. once we return in the spring. We have one exception to this schedule. Our very first seminar of 2021 will be on a second Tuesday, which will be a question and answer session with our new dean, Dr. Carol Bradford, on January 12th. The link to register will be available at go.osu.edu/msgr-zoom 1 week ahead of that session. We are still accepting nominations for speakers in 2021. So you can either submit an abstract for your own presentation or nominate a peer or another student who is doing excellent work at OSUCOM. You can use this QR code, which links to our Google form, and this form is also available on the Student Council website. Without further ado, I present Dr. Lindsey, who will introduce our speaker today.
Well, welcome to the seminar as we all move into December here with a little bit of snow to get us started. It's my privilege today to introduce soon-to-be Dr. Lansing, who has shown a remarkable interest in rural medicine and also care of the underserved. She came originally to us from Oregon with a very strong science background and has done exemplary work in medical school, as you'll hear today. I come from the same area that she's speaking of, although to my parents' regret, I didn't return and take over my father's practice in a very small rural area. But as you'll see today, the need is great and the rewards are many. So without further ado, I introduce Dr. Lansing.
Well, thank you so much for that introduction, Dr. Lindsey. I'm very grateful for your mentorship and support over the years. I want to thank Bryce and Christina, Allison, and really everyone on Student Council that's helped orchestrate these medical student grand rounds. I really appreciate you inviting me to speak today about leadership in rural healthcare. Before we get started, I do want to tell you that I'm currently in a house without power. So I'm staying in Cleveland with family, and we got about 1 foot to 1.5 feet of snow last night. So I'm on a mobile hotspot and currently without my ring light, unfortunately. But so if I start to lag, please let me know, or if we have any sort of, if we have any speed bumps, I ask for your patience in advance. But as we get started, what I really want to do is challenge the unspoken dogma in medicine. I think it's rarely said outright, but really pervasive in our medical education is the doctrine that national leadership belongs to academic physicians, and that the trajectory of healthcare and advancements in the quality of care, as well as leadership as a whole, is not available to rural physicians. I think that medical students are told somewhat informally that to practice rurally is to settle for less, and that students learn that small community practice is less prestigious and less competitive than academic practice, in part because they're made to believe that rural physicians are not leaders. And if the title of this talk is any indication, I don't believe that's true. And instead, I have 3 points for us to go through on where rural physicians are actively leading and where I think that we desperately need leadership. We'll be talking about leadership within a community, state and national leadership, and then what I'm calling academic leadership for a rural physician. During this talk, my goal is that you'll be able to identify a number of rural health disparities, as well as some of the contributing factors to limited access to healthcare in rural areas. Additionally, by the end of our lecture, I hope that you'll have multiple examples of leadership roles, both local and national, for rural physicians, as well as we'll be able to identify the factors associated with residency graduates choosing rural practice, such that we can begin to brainstorm solutions for addressing the rural healthcare shortage together. So without further ado, let's jump into leadership within a community. I think that this is an easy place for us all to start and agree, because within small communities, physicians are fairly natural leaders. That with rural practice, physicians are known to wear multiple hats. And so in addition to their medical practice, they might serve on the school board, on the hospital board. They often organize cancer screening fairs and high school outreach activities. And because rural physicians are known by their community members, they're often looked to and trusted for guidance. Let me take a moment to set the context of where these physician leaders practice and who their patient population is. Rural communities span across the United States. As you can see here, the green area is the rural land as defined by the 2010 census. So under the 2010 census, roughly 97% of the nation is rural land, home to about 23% of the US population. So this is 60 million Americans that live in rural America. And so while over 20% of the US population lives in rural land, only 9% of US physicians practice in rural communities. So just on these numbers alone, we can see that there's a huge disparity in access to healthcare in rural America. Sometimes when we start to discuss disparities in healthcare in rural America, it might be mentioned that the percentage of the population that lives in rural America has been at a fairly steady decline for over a century, and really since the founding of our nation, at which point something like 95% of the United States in the 1700s was rural. And at the turn of the 20th century, it was about 50% of our nation was rural, and has now declined to about 23%. And so while that's true, that there has been a declining percentage of people living in rural America, the number of people living in that area, living with these disparities, has been fairly consistent over the last 100 years. That there's been around 50 million people, 50 to 60 million people living in rural America. But because the population has grown and the number of people living in urban America has increased, the percentage has gone down. So really what this means is that because the same number of people are living in rural America, there's still the same need for rural physicians, even though the percentage of the population has decreased. So I've really been discussing rural communities without defining what rural means, in part because I think that all of you likely bring an idea, a preconceived idea of what that is, and partially because it's actually fairly difficult to define rural. It's a highly debated topic in Washington, much because where you set the definitions of rural will qualify or disqualify certain communities from funding. So it is continually being debated. But so instead of defining rural, because it's hard to do, I'll just share with you some of the shared characteristics of rural communities. So as you might imagine, rural communities are known to have fewer people living farther away from each other and their jobs, with limited access to cities and the resources that would be available in a metropolitan area. The number of people in the town or the distance from the city, again, are continually being debated, but sort of generally speaking for our gestalt today, we can consider communities of less than 50,000 people living more than 60 miles or about an hour outside of a metropolitan area. The unique characteristics that define a rural community also make rural Americans a very vulnerable population. The geographic isolation, coupled with limited access to healthcare and limited job opportunities, lead to healthcare disparities. So rural Americans are older, sicker, and poorer than their urban and suburban counterparts. Over 10 million rural Americans are over the age of 65, and 19% of rural Americans live in poverty. Across the board, the rates of the 5 leading causes of death, including heart disease, cancer, unintentional injuries, chronic respiratory disease, and stroke, are all higher among rural Americans than urban Americans. The life expectancy in rural America is 3 years shorter than the life expectancy in urban America. Additionally, the rural suicide rate is almost twice as high as the urban suicide rate. So this is an incredibly vulnerable population that does not have access to the same amount of physicians as the other opportunities that would be in our nation. So because An additional difficulty that rural communities face is difficulty retaining talent and wealth. The so-called talent and wealth exodus has been well defined in global health, but it's applicable to rural America as well. That those in the community that have financial means or the talents and skills that would grant them social mobility might use that mobility to move to an urban or suburban area with more resources and job opportunities. Meaning that sometimes in these communities, the population that remains is more vulnerable and less socially mobile. So the combination of these factors makes physicians who are willing to serve a small community really natural leaders within that community. A really great example of a rural physician taking on leadership roles within their community is Dr. Lindsey's father, as he alluded to. When I met Dr. Lindsey, I knew that I had an interest in rural surgery, and so I wanted to meet with the surgery clerkship director here at Ohio State to talk about the possibility of doing a rural surgery rotation. And I was kind of worried about what he might say or that he might even discourage this goal. But really instead, Dr. Lindsey told me that he knows personally the large role that rural physicians play in the community and the tremendous service a rural surgeon does for a small community because his father was a vascular and general surgeon in Kenton, Ohio. Kenton, Ohio, as you can see here, it's about 70 miles outside of Columbus, and it's a population of around 9,000 people. So Dr. Lindsey, or Dr. Lindsey Sr., I should say, in addition to serving as a vascular and general surgeon for 43 years, he was also the coroner, a member of the school board, and he served on the Sheep Association board. I actually probably didn't have to tell you he was a rural surgeon. I think you could have just heard that he was on the Sheep Association board and pieced that together for yourself. And I never met Dr. Lindsey Sr., but I'm guessing he loved his job because 4 of his children wanted to follow in his footsteps. Our very own Dr. Lindsey, a cardiac and vascular surgeon, as well as his brother, who's an OB-GYN physician, and then 2 other brothers who are colorectal and another rural surgeon. So this is just another example of the true number of leadership roles that rural physicians can have in their community. And we've discussed it. This is an example of individual leadership positions, and that will vary for various rural physicians depending on what their passions are. But what is not unique is that all rural physicians have a huge impact on the economic viability of rural hospitals and subsequently on the functionality of the hospital and the trajectory of healthcare in that small community. So I want to stop for a moment and discuss the rural hospital closure crisis, that over the last 10 years, 120 hospitals in rural America have closed. Ohio has had 2 rural hospitals, one in Fremont and one in Nelsonville, closed due to economic non-viability. The National Rural Health Association predicts that close to 1/3 of all rural hospitals in America are at risk of closing within the next decade. That represents 673 hospitals in 42 states. There are 11.7 million Americans that are at risk of their local hospital closing its doors. And truthfully, the COVID-19 pandemic has actually accelerated the rate of rural hospital closures. So these hospitals are at risk of taking a huge hit when elective procedures and various procedures are shut down because of the COVID-19 pandemic. That while right now the estimates were, or previously the estimates were 673 hospitals that were at risk, it's likely much more now. And the rate at which they will close is probably potentially shorter than the predicted 10 years. Hospitals in small communities are much more than a place for patients to seek medical care. They're also an integral part of the community. So I want to use a small town in Bowie, Texas as an example to illustrate what it truly looks like when a hospital closes. On top of just the fear and anxiety that I think it would put in a community if you didn't have a place to go, if there was an emergency, if you were giving birth, anywhere that you would seek medical care. In addition, when a hospital closes, or when this hospital in Bowie, Texas closed, immediately 100 jobs were lost. Everyone that was employed by the hospital no longer had a job. So over the course of the next year, sales tax revenue dropped by close to 40% because people have difficulty putting money back into the economy when they don't have an income from their job. So what we're seeing now in Bowie, Texas is that many of the houses are being put on the market. School enrollment is dropping, and they're starting to see businesses leave the town. And so you might start to think of it a bit as a ghost town, but that's certainly not true at all, because there are still people living in Bowie, Texas. It's the most vulnerable, the people with the least social mobility, that will stay there without a hospital, without jobs, and really without a functioning economy. So physician leadership in small communities is much more than their individual practice and their individual leadership roles. Rural physicians are pivotal to the revenue of rural hospitals and the economies of small towns. In America, truly, we've relied on the specialty of family practice physicians to address the limited access to healthcare in rural America, but this current model is unsustainable. Rural hospitals need more than just family medicine physicians to create a steady revenue. They need surgeons and hospitalists, anesthesiologists, obstetricians, psychiatrists, radiologists, and many more to turn a true profit. So not only do rural communities have the surgical and obstetric and other patient needs, but the presence of those physicians in rural communities directly leads to the hospital being able to maintain a profit and keep its doors open. Being a physician leader in a rural community means knowing that your position in that town helps everyone by allowing for the hospital to stay open, not just the patients in your practice that you will directly help. So I've had the opportunity to speak with a few rural hospital CEOs at the Rural Health Policy Institute meeting that we'll talk about a little bit later. And what I have heard is that a functioning general surgery department, so between 2 and 3 general surgeons, can bring in up to 40% of a rural hospital's yearly revenue. Meaning that if you go into practice as a rural general surgeon, you and one other friend can be part of the reason that that hospital is able to stay afloat. And I think that's actually incredible, that you could be the reason a hospital exists. We need rural community leaders from every primary care specialty if we're going to address the rural hospital closure crisis. So clearly we've demonstrated that there's a need for rural physicians, as well as that rural physicians are truly a pillar of their community. But I also want to point out that, like true leaders, rural physicians are also imperative in a time of crisis. As one would imagine, COVID is hitting rural communities hard, not only in accelerating the rate of rural hospital closures, but also some sense of overwhelming small communities and overwhelming their limited healthcare resources. So rural Americans have higher rates of multiple comorbidities, including COPD and diabetes. And in general, as they're older and with lower health literacy, the leadership from local physicians is imperative to the success of protecting the community and saving the very limited number of ICU beds. Let me talk a little bit about why this is on the screen. So this is a very interesting publication from the American College of Surgeons. It outlines how 9 rural surgeons responded to the COVID-19 pandemic in their community. It's a very interesting read, and I would highly encourage anyone to take a look at it if you're interested in healthcare in a variety of settings. But I do want to highlight a quote from Dr. David Welsh, a general surgeon in Batesville, Indiana. So Batesville, Indiana here is a small town of around 7,000 people, and the closest metropolitan area is actually Cincinnati. It's 50 miles away. So Dr. Welsh writes, since early March, I've worked with my county health department to give guidance on and policies to a variety of businesses and organizations, from schools, churches, government services, hair salons, grocery stores, daycare centers, and much more. He goes on to describe utilizing the direction and guidance from the American Medical Association and the American College of Surgeons to inform the local recommendations that he established with elected officials, which they then shared those with the Indiana State Health Department, and their guidance was utilized across the entire state of Indiana. So this is a true example of a rural physician taking on local leadership that even has a statewide impact. I want to point out that the COVID-19 pandemic is a really incredible and tragic example of physicians stepping up from across rural and urban communities to advocate for policies that decrease virus spread and save lives. And many physicians have taken on leadership in the form of public health advocacy, but I want to point out that rural physicians are among that group. So as we transition into discussing rural physicians in national leadership positions, I want to acknowledge a few things. First is that many, and I might even venture to so far as to say most, rural physicians might not seek out national leadership positions. And this is by no means an attempt to push that one form of practice is above another. Rural, urban, local versus national leadership, they all provide care to people across our nation. And the true goal of the latter half of this talk is just to provide examples of rural physicians being national and academic leaders with the intention of showcasing that it's possible. So what does it actually really look like to have a national impact when you're practicing in a town that can fit in a single photo on landscape mode? And there are, of course, many ways to establish leadership at a large level, but I would really like to share with you the accomplishments of two physicians who I've had the pleasure of being mentored by during my time here at Ohio State. We are incredibly fortunate at Ohio State College of Medicine to have multiple rural practicing physicians that are highly regarded at a national level when it comes to rural healthcare. First, I'll be discussing Dr. Randall Longnecker. He's a family medicine physician and professor at Ohio University in Athens, Ohio. And then we'll talk about Dr. Michael Sarup, a general surgeon in Cambridge, Ohio. So Dr. Longnecker is a nationally recognized leader in rural healthcare and an advocate for rural healthcare. He's also the Assistant Dean of Rural and Underserved Programs at Ohio University Heritage College of Osteopathic Medicine. He was the program director of Ohio State University's rural program of their family medicine residency until 2011. And he was a comprehensive family medicine physician, including maternity care from 1982 to 2012 in Bellefontaine, Ohio. Bellefontaine, Ohio has a population of 13,000, and it's about 60 miles away from Columbus. Dr. Longnecker is an active member of the National Rural Health Association, and he's been invited to give talks at the annual Policy Institute, and been invited to speak about rural health at a national level as a consultant on Fox News, the Association of Medical Colleges, and on Kaiser Health News. His most recent form of national leadership is in advocating for rural residency training programs and launching the RTT Collaborative. RTT stands for Rural Training Track. And the RTT Collaborative, it's a nonprofit organization that works with residency programs to develop rural training programs and disseminate that information to students as they choose their residency training. So it functions not only to increase the number of residency programs with rural training tracks, but also to make sure that that trainees know about the existence when they're applying to residency. So in Dr. Longnecker's position as an executive director of the RTT Collaborative, he often travels to residency programs in urban areas and helps them plan and implement a training track located in a rural community. So this is the current map here of family medicine residency programs with rural training tracks. It is available on the RTT Collaborative website for students who are interested in rural practice and would like to identify strong rural training programs. As we've discussed, the field of family medicine has largely taken on the responsibility of addressing the rural physician shortage. And so most of these programs are family medicine, but there are a few in gray listed here that are internal medicine, psychiatry, OBGYN, and some surgery programs listed as well. The rationale behind training programs with rural tracks is twofold. First, that general practice in a rural community requires dedicated training so that graduates will be well prepared for the nuances of small community practice, including the limited healthcare resources and limited specialty referral ability. But second, one of the greatest predictors of a resident choosing to practice in a rural location is if they've trained in a rural location. So we're very fortunate, as I've mentioned, at Ohio State to benefit from Dr. Longnecker's leadership. He and his administrative assistant here, Dawn Malika, coordinate a yearly rural health scholars retreat in which medical students from all Ohio medical schools are invited to join together in Hocking Hills and spend the weekend discussing issues related to rural healthcare, with discussions guided by rural physicians and guest speakers. Each year there's a theme. We've discussed geriatrics in rural medicine. The next year I actually nudged Dr. Longnecker enough that the theme was rural surgery and other necessary aspects of primary care. And then this year we focused on public health in small communities. The retreat is in October every year, and OSU students are welcome and encouraged to apply and attend. From that rural health retreat, Dr. Longnecker and Dawn invite 2 students to attend the National Rural Health Association annual meeting, as well as the NRHA Policy Institute in Washington, D.C. I am pictured here. I attended the Policy Institute with Dr. Longnecker and Dawn, and it was really an incredible experience to hear from so many rural physicians who are real national leaders. The first day of the conference is a string of talks and panel discussions that gives the audience the information about rural healthcare disparities, as well as current policies that are up to be voted on that we're either advocating for or potentially have problems with. And then the second day of the conference, we all actually hike up to Capitol Hill to meet with our congressmen and women to advocate for those policies that we've discussed, and especially those that benefit rural Americans or rural training for physicians. Attending the Policy Institute really shaped how I want advocacy to fit into my career as a surgeon, and I would really highly recommend any students listening that are interested in rural health to keep an eye out for the annual Rural Health Retreat this coming October for the opportunity to then attend the Policy Institute. So as I've mentioned previously, and we've really discussed, and I think you've seen, that the field of family medicine has responded largely to the rural healthcare shortage, and the majority of the leaders at the Policy Institute were family medicine trained. And for that reason, I want to take a moment to highlight a surgeon I had the pleasure of working with, who is a great example of national leadership in his community. So Dr. Michael Sarup, he's a general surgeon in Cambridge, Ohio. In addition, he's also a very active member of the American College of Surgeons, which is the largest and broadest professional society for surgeons in the United States. Dr. Sarup, he's a past president of the Ohio chapter of ACS, and he was actually the first rural surgeon to be elected to this position. He's also the chair and a founding member of the ACS Rural Advisory Council, as well as a co-chair of the Commission on Cancer in the state of Ohio. Cambridge is a town of about 11,000 people, and it's located at the foothills of Appalachia, about 80 miles east of Columbus. So the Rural Advisory Council is a powerful branch of the American College of Surgeons. Under Dr. Sarup's leadership as chair, the council has created rural general surgery residency programs, as well as helped establish residency established residency programs create rural training rotations. Similar to Dr. Longnecker's work, they focused more on surgery with the backing of a professional organization as opposed to a nonprofit organization. Additionally, the Rural Advisory Council has published a number of papers on what programs need in order to train residency graduates that could graduate and enter rural practice, such as extensive endoscopic training and even surgical obstetric care in some cases. As well as they've published about which programs in our nation have the training focus that would prepare graduates for rural practice. This Reap What You Sow paper here would be very relevant to anyone creating a list of residencies to apply to if they're considering general surgery or rural practice. And really lastly, the Rural Advisory Council has utilized the voice they have from the large organization of ACS to work with policymakers and make changes to laws and policies in Medicare reimbursement that had unintentional consequences for rural and critical access hospitals. So I would be remiss if I did not talk about Dr. Sarup's broad scope of practice. So in addition to his very busy work on the Rural Advisory Council, Dr. Sarup has performed in 1 year. This is his caseload from 1 year. He performed over 400 surgeries and 1,100 endoscopies. We can look through this case to see that he has a very broad scope of practice. So in addition to the bread and butter general surgery, lap choles and hernias, he's also doing bowel cases, breast, vascular, a few amputations, and even placed pacemakers in this year. I was actually very fortunate to have the opportunity to do a month rotation with Dr. Sarap, and to see just how broad scope general surgery can be in rural communities. So as I mentioned earlier, with the support of Dr. Lindsey, the surgery clerkship director, I was able to organize a rural surgery rotation with Dr. Sarap in my 4th year. It was a truly incredible experience. I was the only medical student in the hospital, so I was really able to first assist every case that I was in. And I was able to see really head to toe general surgery as well as surgical obstetric care. I think I might actually be the first and only OSU student who ever delivered a few babies vaginally on their surgery rotation. I use Dr. Longnecker and Dr. Sarap as examples, and in hopes that you'll see that national leadership roles are available to rural physicians, but also so that you can see that we have incredible rural mentors here in the state of Ohio. So if you're interested in rural healthcare, I hope that you pursue and look for opportunities, or possibly even create opportunities to do rotations in small communities. So as we transition into our final point, I will acknowledge that academic leadership for rural physicians sounds kind of contradictory. Usually we think of academic as one end of the spectrum and rural as potentially the other. But there are a few opportunities for rural practicing physicians to maintain ties to an academic center and teach rotating medical students and residents. It's fairly uncommon, and certainly there are more rural practicing physicians than there are rural trainee rotations, but this is something that I'm fairly interested in, so I want to utilize the time I have to talk about it. So there are a variety of factors associated with the decision to enter rural community practice, and as we've discussed, those that receive part or all of their residency training in rural areas are more likely to enter rural practice. And this is ultimately the most common cited reason for the work that Dr. Longnecker and the ACS Rural Advisory Council have cited for creating the rural residencies or residency programs with rural rotations. However, the greatest predictor of a residency graduate entering rural practice is if they grew up in a rural area. People with rural upbringings are 2.5 times more likely to enter rural practice than someone from an urban upbringing. And yet, the percentage of US medical students who are from rural areas has been at a steady decline for the last 20 years. We're now at only 4% of US medical students being raised in rural areas. And the truth is that it's actually very difficult to get to medical school from a small town. There are fewer educational opportunities, and unfortunately, a smaller percentage of high school graduates go to college from smaller towns. At my high school, only 22% of the high school graduates complete a 4-year degree. So as that being a prerequisite for medical school, when fewer people do that, there are fewer students that could apply to medical school. Additionally, when there are fewer physicians in an area, and with most of them having a lot of distance and time from medical school, the process of becoming a physician can be somewhat of a mystery to teenagers and adolescents in rural towns. So I'm from Grants Pass, Oregon. It's a small town that you see here. It was about 20,000 people when I was growing up there, and it's about 260 miles or 4 hours from the nearest and the only academic center in Oregon, which is in Portland, that you see in the northern part of the state. Conveniently, Grants Pass is also the location that the only academic center where they send their general surgery residents to do a year-long general surgery rotation. So they have one of these rural training tracks, and it's actually the longest one in the nation. It's a year long, whereas most of them are between 1 and 6 months, really. So these fourth year residency trainees come to Grants Pass, and they spend a year living in the town, gaining operative autonomy while learning about broad scope general surgery and what it means to be a rural surgeon. And when I was in high school, one of the local surgeons invited me to shadow his OR because he knew that I was interested in medicine and he wanted to encourage it. And I was actually able to meet one of these residents. This resident mentored me. He taught me what it meant to pursue medicine and surgery and the steps that I would need to take to get there. And I actually don't think that I would be in medical school if it wasn't for his early guidance. So truthfully, the rural surgery rotation in Grants Pass was initiated with the same intention that we've been talking about, that some of the residency graduates might be interested in staying in Grants Pass or another rural town as a rural general surgeon. In our town, the surgeon told me, it's really difficult to get residents to even come down here. So if they come down for a year-long rotation, if they build relationships in the community, if they even potentially consider buying a house, it would be much easier to recruit them as surgeons. I want to pose another question though, and this is really what I hope to be able to dedicate my career to, is that perhaps the greatest impact on sending residents to rural communities is not on the graduating residents themselves, but potentially it's on the youth of the community. When rural physicians maintain academic ties and take on these leadership roles where they're hosting residents in small towns, small town kids get to meet medical residents. We meet them at the grocery store and while shadowing, or when our family members need medical care. And I think it sounds really simple, but meeting a resident can be transformative when you don't know what it entails to become a physician and when you've never seen a young person as a doctor. So that is academic leadership for a rural physician, and that's really where my passion lies. I want to maintain ties to an academic center as a rural surgeon so that my community is less isolated and so that we can train potential future rural surgeons, and that potentially 10 years down the line, students from my community will enter medical school and we can grow the percentage of medical students with rural upbringings who would then have a higher chance of going into rural communities and making a difference in multiple specialties, not just surgery and not just family medicine. So as I conclude, I do want to thank you all for listening today. Leadership in healthcare leadership in rural healthcare is a topic really near and dear to my heart. I'd be happy to talk with any of you more about it. So please don't hesitate to send me an email if you want to talk about opportunities for rural training or leadership, or if you just want to tell me your rural story. Thank you again, Dr. Lindsey, for the support that you've shown me. Thank you to OSU-COM for allowing me to pursue the rural surgery, and to student council here, the student council group, for inviting me to talk to you all about this today. You're welcome to submit any questions that you have.
Thank you very much. I'll start off with a question for you too. In a situation like you're talking about, commonly the questions arise about raising one's family in a rural area, either a partner or spouse finding occupation or living, or finding adequate schools for their children and that type of thing. Did you get any feeling from the surgeons that you work with about their families and how they had adjusted to living in rural America?
Well, that's a great question, Dr. Lindsey, and clearly we can use you as an example as someone who grew up in a small town and is now, the clerkship director and a really successful surgeon at Ohio State, as well as your family who have majorly become physicians. It's true that that's a valid concern that's often brought up, is that if you decide to practice rurally, are you creating a disadvantage for your family? But I would argue that that's more of an urban myth, and that every physician that I have met in a rural community has been very happy that they're able to encourage their children to learn and pursue opportunities. And in fact, as a person that grew up in a small town, I think you become very invested and thankful for the opportunities that you have, that it's not so much that they don't exist, but just that they're fewer and farther between in smaller communities. And so there are opportunities for your children to learn. I did also, one of the interesting things that came up is that for physicians who decide to practice rurally, those with spouses that were not from a rural community, actually there was no difference in the length of time that they practiced in the small community. So I think the challenge just becomes convincing your family to move to a small town, as opposed to once they get there, they really, it seems that the evidence shows that they like it and they stay. Excuse me. Whoops, sorry everyone. Bear with me. Share screen.
I don't know if you have access to the question and answers. There are several good questions there to go on. Let's see if I can summarize some of them.
Well, while you're doing that, let me answer the question that Christina posed in the chat for us.
Please.
Yes. Oh, I promise I am technologically competent, everyone. Okay, here we are. So Christina asked, do you think there's a role for physicians in cities to go into rural communities part-time? Have you seen any examples of hybrid practices? So that's a great question, and it is, I have seen a lot of examples of hybrid practices, and I think that they work to some degree, but that they're not a long-term solution. So it's a very short-term solution to people not having access to healthcare, that someone might go into a community and do whichever their specialty is. Especially sometimes surgical subspecialties will do that very often, because it can be very difficult to recruit something like a urologist to a small town if they don't see as many cases as they would see in an urban setting. The unfortunate part about it is you lose a lot of what we've been discussing when you live in a community. As a physician, there's a lot of leadership roles that come from that. There's a lot of trust that comes from that, and patients are willing to come to you. They see you in the store. I actually heard a rural physician once say that he gets as many referrals in the local Walmart as he does from local physicians, that he sees people that he knows as community members because he's living in that town, and that then he's able to take care of them really holistically. So in addition, while there is some degree of, if in a hybrid practice, when a physician goes to a hospital, they are generating some revenue for that small hospital, but it's not the same amount, and it really doesn't help the rural hospital as much as obviously as a full-time practitioner there. So I think that as opposed to treating the symptoms, we really need to get to the core, which is if there are not enough rural physicians, if there are not enough physicians in rural America, what we need to do is create more rural physicians.
I can answer a couple quick questions. There's a question about the financial issues. In America today, most people don't know, but there are things called rural clinics. And so with the federal government, certainly under Medicare, and with the state's governments under Medicaid, there is additional reimbursement higher than the urban centers for a standard visit, for an operation, et cetera. I can't quote you the numbers, but the finances are not the difficulty in terms of the physician, and the amount of work is not the difficulty either, because there are some people currently, my dad's been gone now almost 20 years, and there's not been a surgeon there. And there is a surgeon that comes from Dublin 3 times a week and essentially uses it as an outpatient center, doing a lot of elective type surgery. So that's one method as we expand to at least get some of the care local. We'll look through some of the other questions maybe in the meantime here.
One question that was asked was, what are some ways to increase the pipelines of physicians from rural backgrounds? And I actually just, at the annual Rural Health Scholars Retreat, I actually was talking with a hospital CEO who they're in Indiana, where they have a outreach program for their high school students, where the high school students have to go through a dedicated curriculum where they're doing a lot of shadowing and even going on some ambulance rides and doing, I don't know the entire scope of it, but if they complete this course and then go to an Indiana State University, they were actually, according to this hospital CEO, guaranteed a interview with the Indiana University, with one of their campuses, because the Indiana University medical system has multiple campuses for their medical schools. And so I thought that was a very interesting rural outreach pipeline program where, at the very least, if someone is showing a long-term dedication to medicine, even if they don't have the same opportunities, they're at least offered an interview with a medical school, which is a really tremendous accomplishment.
I see Ryan has a question about burnout, and yes, that's a problem, but one of my younger brothers is a rural surgeon. And what happens is that it's such a small town that they know when the doctor's worked all night. And so what they do is when he needs to sleep, they transfer patients just as they did before they didn't have a surgeon. So it's amazing how in a small town, the communication gets around and the doctors watch out for them. But the scope of practice is an important thing. Most people don't know that most of the C-sections in the country are still done by family practice and general surgery, because we ignore the rural population. We think in terms of urbanness and think, oh, gee, we can only have babies delivered by obstetricians and not by family practice and not by surgeons. But I think that aspect of burnout is something that's been worked out pretty well by the local communities because they know what a resource they have.
Absolutely. And I've heard that burnout really depends on the number of, at least in general surgery, the number of general surgeons you have. So certainly if you're the only general surgeon in a community, that makes your call time about 24/7. Whereas when you can get up to at least 3 in a practice, I've heard from Dr. Sarup that that's the sort of sweet spot for them, that they then only have to take call about once every 1 or 2 weekends a month, and they're really able to enjoy their time and prevent that burnout. So someone asked how medical students can learn more about rural medicine outside of research opportunities. And I do want to address that I think that the emphasis that we don't have an emphasis on rural healthcare, and that probably contributes to the lack of rural physicians that we generate as a country. But I would just encourage you to certainly look for the opportunities that come out. There's the annual health retreat that we talked about, as well as just reaching out to some of these rural physicians to talk to them. But truly, you can create opportunities in rural healthcare if you don't see them. So, when I met with Dr. Lindsey and I said, I'd really like to do rural surgery, and he said, okay, yeah, let's do that. He knew Dr. Sarup, so he could vouch that that was going to be a good learning experience and that I wasn't just going to go and twiddle my thumbs for a month. And so that was an important validity that he contributed. But I think that if you don't see an opportunity in rural healthcare, that you should create it or pursue it by reaching out to mentors. So Dr. McAllister asked if there's, she mentioned that she went to a school that required rural health training experience, and that she found it really meaningful, but she was curious to talk about if those programs had success in attracting future physicians back to those practices. And I don't know exact numbers. I can tell you that right now, 1 in 4 medical students in America that are from a rural upbringing go into rural practice. So we discussed the 4% of medical students that are from a rural background. And so only 1% of total medical students will end up going into rural practice at the end of residency. I'm not sure. I know that medical school having a rural outreach program is less of a predictor than going to a residency program that had a rural track, but that it's still more, they still produce more rural physicians than medical schools that don't have rural outreach.
There's a question about whether you need to do additional fellowship training. And I think you need to remember that when in the current population, 80% of the surgeons do go on to types of fellowship, but 20% go right on to work, whether it's in an urban setting or a rural setting. Oftentimes, if they choose to practice in a very remote area where they need the training for obstetrics, they will spend a month or two extra. And also their colleagues who have been doing it for years and years will be great mentors to them to get to do the things that they need to do. And most hospitals still have all kinds of helicopter traffic and ambulance traffic for things that are beyond the scopes of as we see here at Ohio State from the trauma, neurosurgical problems, et cetera, that get those patients well evaluated and then sent to us directly and facilitate the care by having a knowledgeable local physician make the original diagnosis and get them out of there. So I think the answer is yes, you can go right to work. 20% of the population of surgical residents currently do go straight to work after their 5 or 6 years of training.
I know that there has been talk about in the future of adding a rural surgery fellowship. I don't know that we're going to see a huge change in the way that training is right now, but I think that one thing that's important to remember is that your training does not end at the end of residency. That ideally, if you were to go straight into practice, or if I decide to go straight into practice, one thing that I'm going to consider is that I'd like to go to a community that has a senior surgeon that I can continue to learn from. That it would, I've heard that burnout rates are high and that the success rate is low for surgeons that go directly from practice to a small community where they're the only surgeon there.
And in addition, although today we're talking about surgery, I need to talk a little bit and put a plug in for our primary care. Most of you know Dr. Philip Binkley, who's head of FAME. His father was really my father's best friend. He was the internist in the town that I grew up in. With a surgeon and 2 or 3 good internists or family docs, you can take care of a large population, even though you're 35 to 40 miles away from another hospital. And I think that's important. In my day at Ohio State in medical school, 2 of my fellow classmates actually slept in my bed up in Kenton and spent a month with my father. And that process continued for many years. It hasn't been recent, but those types of experiences can be opened up again once we get past COVID. It's just a matter of interest and a matter of arrangements. Thank you for your time.
Thank you both for such a wonderful discussion, and thank you all, everybody who watched live and everybody who will watch in the future. This is a great wrap up to our 2020 seminar series, and thank you very much.
Thanks a lot.